My name is Naveed Sattar. I'm from the University of Glasgow and I am Professor of Metabolic Medicine. Our paper was actually stimulated by findings in prior studies, particularly the Jupiter study, where they found a high risk of diabetes in those allocated to active rosuvastatin as compared to placebo. Now, we were interested in this finding because we had ourselves conducted a prior study back in the 1990s suggesting a low risk of diabetes, but when we looked back at other papers, there seemed to be a consistent trend towards potentially higher risk. So our aim was in this particular study is to retrieve all data that we possibly could from randomized trials. So those are trials of active treatment as against placebo for statin trials with more than 1,000 patients and more than 1 year follow-up. And of the 15 trials that we were able to locate, we managed to get data on 13 of those trials, which includes 6 that had already been published in terms of diabetes rates and another 7 new data sets. So in a sense, it was data collected from randomized placebo-controlled trials looking at diabetes endpoints on statin versus placebo recipients. We observed or determined that overall patients who were allocated to statin had on average a 9% increased risk of development of diabetes, which was significant compared to those who were allocated placebo. If you take that a bit further, 9% increased risk of diabetes in the number of patients that we had actually looked at, which was over 90,000 in the randomized trials, equates roughly to 1 in every 250 patients taking treatment for 4 years developing diabetes. Now you have to contrast this with approximately 9 patients being prevented from developing cardiovascular events, which includes heart disease, heart attacks and strokes. So on balance, we considered that the benefits of statins far outweigh any increased risk of diabetes for those patients who regularly require statins because they are at medium to high cardiovascular risk. So overall, our conclusions were whole-scale therapy for statins should not change worldwide on the basis of these treatments. We did, however, put a caveat that patients who are at low risk of cardiovascular disease may wish to consider the diabetes risk for proper evidence base, where there may be an indication that patients at low risk of cardiovascular disease perhaps should not be put on statins based on their risk of diabetes, but that I think needs to be developed further in future trials. I think before we even talk about biological explanations, some colleagues and some experts in the field have considered or wondered whether this is potentially a rogue finding due to increased survival of patients or some other confounding issue, and we have determined that at least increased survival does not seem to be the explanation for this finding. If you then think that actually diabetes as a condition is driven by abnormalities in a number of organs, including of course fat tissue and also in particular muscle and liver, and then that statins' major side effects appear to occur, well actually do occur at the level of the muscle and the liver, it doesn't take a rocket scientist to work out that statins may be interfering with processes within liver and muscle, albeit subtly, to affect glucose metabolism. One example could be altering muscle mass, for example, or just muscle activity, or just to affect muscle in the way that people perhaps are slightly less active in a simplistic way, or perhaps having effects on molecular mechanisms at the level of muscle which interferes with glucose metabolism. Equally at the liver, pathways to do with glucose disposal or gluconeogenesis may also be interrupted by statins, but these are very speculative suggestions thus far. I think the simplistic interpretation is statins we know affect muscles and liver, and these organs we know are relevant to diabetes. So that I think is probably where most researchers will focus their attention on to try and work out exactly what the potential mechanisms may be.